Hello, everyone, and thank you for joining us for our latest Ask the Mito Doc webcast. Tonight, we will have 8 clinicians responding to questions on video and off video. Dr. Philip Yeski will be our moderator this evening. 4 clinicians will be on video while the other 4 will be typing responses to your questions. At the 30-minute point, we'll switch those off video and give the other group some camera time for responding. For the first 30 minutes on video, we will have Dr. Andrea Grootman with Children's National Medical Center, Austin Larson from Children's Hospital Colorado, genetic counselor Colleen Clark-Marescu from Children's Hospital Philadelphia, and Dr. Mark Tarnopolsky from McMaster University in Ontario, Canada. On the last 30 minutes, we will have Dr. Rebecca Ganetsky from Children's Hospital Philadelphia, Dr. Relitsa Gavrilova from the Mayo Clinic in Rochester, Minnesota, Dr. Sumit Parikh from the Cleveland Clinic in Cleveland, Ohio, and then Dr. Hilary Vernon from Kennedy Krieger Institute in Baltimore. Our Ask the Mito Doc webcasts are made possible through the generosity of these sponsors, so we ask that you join us in thanking them for their support. Thank you, Edith Trees Charitable Trust, Akron Children's Hospital, PTC Therapeutics, and the Jack Edwards Family Impact Fund. We are thrilled to have this special announcement. UMDF's Mito Clinical Trials Finder is now available. So please take some time and visit www.umdf.org/clinical-trials. This is a great tool for searching, identifying, and enrolling in mitochondrial disease clinical trials, and it's all in one place. Great user-friendly tool, so check it out. We are excited about Mitochondrial Medicine 2022 live in Phoenix, Arizona this coming June. Take a look at your calendar and save the dates. And make sure you visit www.umdf.org/symposium and go ahead and reserve your hotel room. You want to make sure you get a room and join us in June. UMDF's Give Energy program has launched. To read more about Addie's family and giving the gift of energy for all of our UMDF patients and families, scan here or visit www.org/giveenergy. Before we hear from our panel, we have some housekeeping items for you. We have muted the lines, so if during this webcast you have a question, please use the Q&A button to type in your question so that we can get answers for you. We ask that you keep your questions short for this webcast. We may not be able to answer questions that are too personal or detailed for this forum. Also, please note the information about the closed captioning at the bottom of your screen. Looking ahead, next month we will start the year with transitioning medical care to adulthood. We are excited to begin our year with the Child Neurology Foundation and Dr. Bruce Cohen. Watch your email and social media for ways to register and to submit your questions. Now it's time to get started, and Dr. Phil Yeski and Margaret Moore, our moderators this evening, will start out our special Q&A.
Hello, everyone. Wonderful to be with you this evening. Spend some time on this special Ask the Mito Doc webinar, end of year. We're really fortunate to be joined by a fantastic panel. 8 representatives from the healthcare profession that are taking care of our mitochondrial disease patients, all making time to answer your questions. And we've received a lot of questions in advance, and I'm going to pose some of those questions to the panels and let them respond to it. I think there will naturally be some follow-up questions that come out of that. But as Kara just described in the introduction, if you have any specific questions that you'd like to ask, please use the Q&A function. We'll be keeping track of that. And as time allows, we'll do our best to get to them as many as possible. And the doctors that are off screen will also be keeping an eye on that and trying to respond to. So this is a great opportunity to put your questions forward. And I think without further ado, let's jump in. So Kara introduced our first panel, and I'm going to just start with a question that I think many of our mitochondrial disease patients, or many in the mitochondrial disease community, are asking on a regular basis. What's the most effective way to obtain a clear diagnosis of mitochondrial disease today? So, Colleen, you're a genetic counselor. Why don't you kick us off there with that perspective, and then maybe we can jump to one of the other doctors.
Sure. I feel like I'm a little biased with genetics in my title, but genetic testing, especially with the field that we're moving into clinical trials, is the most non-invasive, effective way to obtain a confirmed diagnosis. We've kind of moved away from just clinically categorizing patients, as that can still be powerful in a lot of ways, but to obtain that definitive diagnosis, genetic testing is still the best tool, and updating your genetic testing. So if you were negative several years ago, it's always great to check back in with your team to ensure, have you had the most up-to-date testing based on technology and everything? Is there anything additional that you need to proceed forward with? And yes, we still do biopsies, and they can be effective, especially in light of non-invasive testing being unremarkable.
Great. And maybe Dr. Tonopolsky, you may have some opinions on this. You've seen the diagnostic criteria change, right, over time in the mitochondrial disease space. Anything you'd like to add?
Sure. So I think the most important thing in mitochondrial medicine, as is the case with all aspects of medicine, is the appropriate history and physical examination. And to get that done properly, you've got to see the right person. Because if you don't ask the right questions and do a thorough neurological examination, you're going to miss many findings that are sometimes subtle and or overcall things. And then if you do genetic testing, for example, on someone with a low pretest probability, the challenge there is that you get variants of uncertain significance. By that, I mean, you get something that, a rare mitochondrial variant, which may mean absolutely nothing. And then people carry an inappropriate diagnosis. So I can't emphasize enough, maybe because I'm probably the oldest one on this call, history, physical examination, full neurological examination. And then from there, we do a series of tests, usually simple things like CK, lactate, plasma amino acids, and urine organic acids are a good first start to complement a good history and physical examination. And although I've done more biopsies than anyone else in the world, now approaching 22,000, most of those are for research, we are certainly moving away from that for some, but not all diagnoses. So for example, some disorders like chronic progressive external ophthalmoplegia, there's really nothing you can do in the blood. You have to do a muscle biopsy. But again, that's only after a careful history and examination before we progress to the appropriate testing. But again, it's seeing folks like the folks that you're seeing now, and in the second part of this to get a proper diagnosis. That's the first step. And then they'll order the appropriate test.
Yeah, fantastic. I don't know if Doctors Grotman or Larson have anything else they want to add on this front.
Yeah, I mean, I agree. So I actually was a fellow during the time when we were doing exclusively biopsies, because we didn't really have molecular genetic testing, and then it started to come into being, but we were very limited in terms of what we could test. I think, again, just to stress the history and physical, because there are a lot of symptoms of mitochondrial disease that are non-specific that can also be seen in other disorders. So we certainly don't want to miss other things that could be going on, especially if they have a very specific treatment that would be different from what we would do for a patient with mitochondrial disease. And I think, I always, when I teach the medical students, I always say that mitochondrial disease is like the Where's Waldo, because it shows up everywhere, right? So it's getting to that right person, right? You could be in the GI clinic and they have no idea because they're just looking at their part of the body and ignoring everything else. And you could be in, the kidney clinic or, some other place. So it's somebody who recognizes the unique constellation of multiple systems that are involved and sends you to the right person.
Dr. Larson.
Yeah, I think I fully agree with my three colleagues who have already spoken in terms of both getting the clinical expertise, in terms of having a visit with someone who recognizes the patterns of symptoms that go along with mitochondrial disease, but also, moving that genetic testing fairly early in the diagnostic evaluation, I think has benefit to patients. I think the one thing that I'll add that wasn't fully fleshed out yet is the idea that genetic testing is not a monolithic entity. So you get different results if you test different tissues. You get different results if you're testing mitochondrial DNA versus nuclear DNA. When you test the nuclear DNA, you can test a subset of genes, which is a panel. You can test the coding region of all the genes, which is the exome, or increasingly we can move to whole genome sequencing, and then the next step after that is something called long read sequencing. So we can sort of see the trajectory of what the genetic testing is looking like right now, in the past, as well as in the near future. But I think in terms of the likelihood of finding a genetic diagnosis, there was an exponential increase over the course of a few years as we both got to using next generation sequencing technologies for mitochondrial DNA and had the ability to find low levels of pathogenic mutations. And also as we started to use whole exome sequencing and had the ability to have sensitivity for a wide variety of different nuclear DNA mutations that cause mitochondrial disease, there was a rapid increase in our ability to accurately diagnose mitochondrial disease. And there's still a few folks that clearly have mitochondrial disease who don't get diagnosed genetically with current technologies. And to Colleen's point, we know what's coming. We know that our genetic testing that we will have available in a year or 2 or 3 years is going to have sensitivity for different types of mutations that we can't detect right now.
I think these are really good points that you make here, right, for our audience in realizing, diagnosis is a journey, and every clinician, every healthcare provider is working with their patients to try to get to that diagnosis as quickly as possible. Oftentimes, it comes in phases, and it may involve multiple tests. It may involve multiple assessments, and the gold standard is definitely next generation sequencing now. I think everybody agrees, but sometimes it's just not that simple, and that is the case with mitochondrial disease. But we are seeing rapid improvements year over year, no question about it. But maybe Dr. Larson, we can stay with you here for the next question. A question was posed before the webinar around temperature regulation in mitochondrial disease patients. Again, wide variety of symptoms, right, that are observed. That some sweat quite a bit, others don't sweat at all. So, can you just speak to sort of that component of the mitochondrial disease symptom makeup?
Sure. Yeah. So we see, I certainly see a number of patients who have temperature dysregulation as one of their symptoms, and that can be in either direction. So people who either feel like they're always hot and they don't tolerate heat, people who feel like they're always cold and don't tolerate cold. There can be a couple of mechanisms for that. So one has to do with the basal metabolic rate of the body. So there are certain mitochondrial diseases where that basal metabolic rate might be abnormally high or abnormally low. Another has to do with the muscle bulk of the body. So someone with very low muscle bulk generates less heat, and they might be intolerant of the cold. A third mechanism might have to do with the autonomic nervous system. So the way that the body regulates its temperature is to control blood flow to the skin or to maintain blood flow just in the core of the body. And so the nerves that control whether those blood vessels are opening or closing, those can be affected by mitochondrial disease, by people who have a neuropathic process. So yes, that definitely is something that we see in the clinic, and there are multiple different mechanisms that can cause that symptom.
Sorry, I muted myself. Dr. Tonopolsky, I don't know if you want to add anything. We probably don't want to get into coupled and uncoupled mitochondria in this setting, but there's really two different pathways, right, that energy can take within the mitochondria, and that plays a role as well.
I think from a general sense, the words that we just heard were very sage advice. I think extremes are always a challenge, even for the able-bodied person. Our body resists changes too far in one extreme or the other. If, for example, we get too cold, we can trigger shivering. Shivering requires a huge amount of energy. So even at rest, if you start shivering, you increase the energy consumption. That can be very demanding for someone who, for example, has maximal oxygen consumption that's only twice the basal state. That could take all of their energy, almost like doing a full 400-meter run for someone who has a severe mitochondrial disease. On the flip side, it takes a lot of energy when you're very hot. You have to sweat. To sweat, you dilate the blood vessels, which requires an increase in your heart's ability to pump and to deliver oxygen to the tissues. And that just puts another stress on the mitochondrial system. So again, those extremes are important to try and avoid. And there's ways that one can do it. For example, in Canada, where it's a little colder, layering your clothes appropriately, wearing appropriate gloves and hat. And I think layering is important so you don't get too hot or too cold when you go out. And in the summer, I think avoidance of not just high temperature, but also high temperature and humidity. Because one of the ways that we dissipate heat is by sweating. And if it's very hot, you can't dissipate heat through sweating. So just being aware of those extremes in temperature, I think, is an important practical thing for most patients to be aware of.
Yeah, great practical advice there. Dr. Grobman, I'm going to kind of toss this one over to you. A question was asked around gastrointestinal symptoms in mitochondrial disease. And, is that something that you see present in all mitochondrial disease patients, or is there a mix? Some are affected by that, some are not.
Yeah, there's definitely a mix. I mean, depending on which mitochondrial, syndrome we're talking about. And also it's not absolute that it has to be there at one time and not another, right? So there's some conditions, thinking, for example, MELAS, that, it mainly strokes early on, but then later in the disease, we start to see slowing down of GI movement, or gastroparesis is the fancy name for that. So we definitely, see it in a number of patients with mitochondrial disease. It's not an absolute symptom, and it's something that can not be present initially and present over time. Again, it's always important to understand what the nature of the GI symptom is. So I talked about one in particular. Some people may have, bloating or diarrhea or vomiting, or, other manifestations of GI dysfunction, because the process of motility in the gut requires a lot of energy, right? So any system that requires energy in a patient with mitochondrial disease can be potentially affected. And, depending on where your energy needs to go at that moment, and how much is left for each organ system, and how much the demand is at that particular moment in time, and that age and stage of development is going to determine what, some of the symptoms are.
Yeah, that is typical of mitochondrial disease. There are very rarely hard and fast rules, right, that apply to all patients, but GI symptoms are very common.
Right, and I'm also a big advocate of ruling out other things. So I did have an adult patient a number of years ago who experienced a change in the caliber of her bowel movements. And her physicians were convinced, because she had mitochondrial disease, that it had to be due to that. And, unfortunately, but fortunate for her, she did have colon cancer, but it was caught at an early stage. So having a mitochondrial disease, unfortunately, does not prevent you from having other, signs and symptoms that can also present with problems in the same organ systems you see in mitochondrial disease. So again, the value of the history and the physical, does it fit? Do we need to rule out other things, is always important to consider. Mm-hmm.
Well, this next question. Oh, please go ahead.
Briefly add to Andrea's point. I think it's very important in patients with rare disease to have a mitochondrial physician, because often everything that happens to that person is attributed to mitochondrial disease. And so often to sort out the wheat from the chaff, and as Andrea pointed out, to not miss common things like vitamin B12 deficiency, cancer, tumors, so many other things are often attributed to the rare disease. And so it's really important to keep an open mind and to go right back to basics with the history and examination.
Absolutely. We have about 10 minutes left with this panel, so I want to make sure that we hit a few more of these questions. This next one, I'm quite confident all the doctors on camera right now are going to have an opinion around, and that's mitochondrial disease and diet. Keto, small meals. Are there any recommendations, any general recommendations that are made, or is this another case where each recommendation is unique to each mitochondrial disease patient? And Dr. Tarnopolsky, we'll start with you and let the others comment.
I think the only hard recommendation would be children with intractable epilepsy, where a ketogenic diet has been shown to be beneficial. And in complex 1 deficiency, there's some theoretical constructs around the delivery of fat, which can partially bypass complex 1. So in the old days, people were afraid of the ketogenic diet, that it might be deleterious. But certainly in a complex 1 deficiency, there's an American Journal of Clinical Nutrition article showing that there are in fact benefits from the ketogenic diet in that context. I think for most patients, being on a ketogenic diet or, whatever South Beach diet, whatever it might be, I'm not sure that there's good evidence for this. I think, getting adequate protein is important. Generally, 1 gram of protein per kilogram body mass is a good recommendation. It's a little bit higher than the US RDA. Beyond that, I think avoidance of simple sugars, processed foods, all the stuff that I think is good for a prudent normal diet would be appropriate. But too much of an extreme in one direction or the other, I don't think there's good precedence for that.
Dr. Larson.
Yeah, I'll just add pyruvate dehydrogenase deficiency as another specific indication for ketogenic diet. Outside of those couple of narrow indications for it, I speak with my patients in similar terms to what Dr. Tarnopolsky described.
Mm-hmm. Dr. Gropman, anything you'd like to add around diet and nutrition?
Yeah, so I think extremes of anything are never advised. And then some patients may have an intolerance for something in their diet, like some of our MELAS patients don't tolerate long chain fats, which is a major constituent of the ketogenic diet unless you go to a more MCT diet. So I think, again, there are some recommendations, but you still have to look at the patient in front of you and you may have to tweak it to that person's needs so as not to have like a one size fits all approach.
Yep, super. So maybe we will stay with you, Dr. Gropman.
I will say, if I can maybe add one thing, I certainly have a subset of my patients with mitochondrial disease that have a very difficult time maintaining their body weight. And so for those folks, I think it's very important to meet with the nutritionist regularly and have regular measurements of, whether it's skin folds or weights or just a very careful attention to the nutritional state, because there are a lot of secondary manifestations of malnutrition that can be avoided if you pay very close attention to maintaining body weight for those that are having trouble with that.
Yeah, probably another case where it's just prudent not to make adjustments in your diet without talking with your doctor, with your healthcare providers who really understand your form of mitochondrial disease best. This is advice that, of course, applies in many aspects of managing disease, but particularly with nutrition. Pardon me. So, Dr. Gropman, I was going to ask you around clinical trial activity, right? I think this is really exciting for our community. There's an increased number of clinical trials. We know there's a lot more clinical trials coming that are being planned. And what we're seeing is a really heavy emphasis placed on being able to find genetically confirmed mitochondrial disease patients to participate in that. We've all talked about how that's an important part of diagnosis and ultimately it's a goal. But of course, that does leave some portion of our community on the outside looking in, if that's an inclusion criteria. Like, what are your thoughts on clinical trials over time eventually evolving to include non-genetically confirmed patients?
Yeah, so I think it really depends on what the nature of the clinical trial is, because they're based on science and some evidence that the compound that they're proposing or the treatment or whatever it is, it may be some other intervention, has some expected biologic relevance, right? So I think by selecting patients who are the most likely to benefit from that, whether it's patients who have a particular shared molecular etiology, a particular mutation, or even complex 1 or whatever the etiology is that affects the change with this intervention, in order for the trial to be successful, they want to make sure you have the right people. And then even with selecting a group of people who maybe have the same molecular etiology, the ability to participate in the trial fully and be able to meet the criteria, the inclusion exclusion criteria is important because of safety and also because of the data analysis. So if they're proposing a 6-minute walk test and the patient doesn't walk, that's probably not a good trial for someone to participate in. I think, right, there may be other trials that are based more on non-specific, non-molecular or non-biochemical measures, but I think it would be, it might be a different type of intervention than a drug trial. But however, there are some trials right now that do encompass a large group of patients, right? So they don't necessarily have one. It's not just for MELAS, or it's not just
Right.
for, Lay syndrome. There are some that have,
basket.
yeah, like a basket trial where you look at one drug but usually the disorders have to share a molecular or biochemical etiology. So you're basically testing one drug with different patient populations. They'll have some shared endpoints and then some different ones. But yeah, I think for the trials to be successful, you really want to make sure you have the right patients enrolled in them.
Yeah, this is a challenging one because obviously we want as many members of our community as possible to be involved in trials for their own benefit, but also because if we don't have an engaged patient community involved in clinical trials, we're not going to have treatments and cures. And I think that's a goal that we all share in terms of what we're trying to accomplish within mitochondrial disease. Dr. Tarnopolsky, I know you've been involved in clinical trials quite a bit. Maybe how have you seen it change? Where do you see it going on this front?
I think an important thing for clinical trials is you need something that's measurable. And so for most of the trials currently, they're looking at mitochondrial myopathy. So you have to have evidence that the muscle is affected. So for example, as Dr. Gropman pointed out, a 6-minute walk test is a common outcome that the NIH accepts as being important to be reflective of disability that people might have in their daily activities. So for example, if you had MELAS syndrome, but you had a very low level of mutation and may get diabetes and deafness when you're 50, you may never have muscle weakness or muscle fatigue. So putting someone like that into a trial, they've already hit a ceiling. So there's no deficit to measure a benefit. So it's really important that whatever the outcome measure is, it's measurable and it's in a range where you can actually see the effect of that. Otherwise, we're going to throw the baby out with the bathwater. Now, as time goes on, even though you might have very restrictive entry criteria to determine if a drug works or doesn't, we can often prescribe these in an off-label manner later on. Right. So for someone with ataxia, which is really hard to measure, the balance in someone, they may well benefit from a drug that works on myopathy, but it'd be very hard to do a study just looking at ataxia because it's a very difficult construct to reproducibly measure. And that's perhaps why some of these seem to be overly restrictive, but everyone's working to the same end, and that is to find something for all of our confirmed patients to benefit from.
Yeah, a really important message, right? That it's because it's science, it's research, there needs to be a very defined cohort of patients that are entered into the trial. But if that intervention can be proven to be safe and effective, it does open the opportunity for a broader swath of mitochondrial disease patients to receive that therapy if appropriate too. So it's not without hope. And again, we really need involvement in clinical trials to be successful on this. Well, I see we're right at 30 minutes. I think it's mandatory in this pandemic time that we have to have a COVID question on each panel. So maybe we'll do this a little bit of a lightning round going around here. There's oftentimes we're still learning, right, about COVID-19. And obviously it keeps mutating and changing, right, over time. But one of the impacts is the so-called long haul COVID, right, where someone affected by it then having to deal with the symptoms much longer, even after initial recovery. Is there a mitochondrial component to that? And is this something that mitochondrial disease patients need to be cognizant of or thinking about? Who would like to start on this front? Maybe Dr. Gropman, I see your microphone's open. We'll start with you.
We can start with Dr. Tarnopolsky.
Okay, Dr. Tarnopolsky, she's yielded her time to you.
I mean, it's a very long question, so I'll try and be brief. First of all, I'd encourage everyone to get vaccinated. That's our best defense against getting COVID. We have a paper in submission where we've seen patients that have had severe COVID, had weakness, and we can actually see the COVID virus inside the mitochondria, inside muscle. So it probably is having a direct effect on mitochondria, but even if there's a secondary effect, someone with primary mitochondrial disease would not do well with the incredible metabolic stress that could be conferred by getting COVID-19. So I'd encourage everyone to be vaccinated. And if you do have symptoms that persist afterwards, again, it's important to look at all of the common things: sleep hygiene, low thyroid, vitamin B12 deficiency, and all those other things. Even severe vitamin D deficiency can cause muscle fatigue. And to treat what's treatable, and then good sleep, good nutrition, and gentle, gradual exercise to retune your mitochondria and rehabilitate yourself would be, I think, the best evidence that we have at this point, and my suggestion.
Anybody else have any brief comments they want to share? We're going to need to wrap up this panel here. If not, I'm going to thank all of you. That was fantastic, great discussion. There may have been a question or two that we didn't get to that we had hoped to get to. So I'd ask you, when you go off camera, if you can take a look and see if any of the questions that have been submitted through the Q&A are appropriate and that you might be able to help our audience with. But thank you all for participating, and we'll allow you to exit stage left, and we'll rally up our next group for part 2. So again, thank you all. So if Drs. Gavrilova, Ganetsky, Parikh, and Vernon would like to come on camera, that'd be wonderful. Very nice. So again, nice to see you all. Thanks for joining. Maybe we can even continue on this COVID question, because the patient community, for some 18 months now, right, have been asking questions about, is it appropriate, or what are my concerns? Do I need to isolate myself? And then new treatments continue to emerge, even beyond the vaccines. And one of those, or recently, it was monoclonal antibody treatment. Is this something that Mito patients should consider taking part in? I know, again, this is something that maybe all of the clinicians may have an opinion on, but who would like to start? Anybody want to put their hand up on that one? Monoclonal antibody treatment. Any concerns for mitochondrial disease patients? Please, Dr. Ganetsky.
Sure, I can start with this. So monoclonal antibodies are a way of helping your immune system fight off COVID. Antibodies are what we all make to fight off infection, and monoclonal antibodies are giving you kind of that extra boost until your body's ready to make your own antibodies. So they're safe, and what we know about them is that they help people who are at high risk for having severe disease from COVID stay out of the hospital. So, what we seem to be finding is that the people who are at highest risk of going into the hospital with COVID are people who have diabetes, heart disease, kidney disease, and other complications like that. And so if you are someone like that and working with your primary care doctor and your Mito team, they agree that you're at high risk and you realize that you have COVID, monoclonal antibodies will help decrease the risk that you'll have severe enough disease so you'll need to be in the hospital. And they're safe to use with mitochondrial disease.
Very, very helpful. It's really about treating someone early enough, right? Early intervention to try and mitigate the risk of severe disease onset. It's really not meant to be for someone that's already been hospitalized and treating them at that point. So it's a rather narrow application for it, but it is an important part of the therapeutic continuum. Dr. Gavrilova, the vaccines. We've heard a little bit on the last panel. Strong recommendation. Everybody should go and talk to their healthcare provider about getting vaccinated and making that happen. But we also continue to hear about variants and changes in the disease. So, thoughts on concerns with Omicron and other variants that may come along, and mitochondrial disease patients and vaccination. Any thoughts to share around that?
So generally what we recommend, until we have more research on the specific mitochondrial population, and you may have heard that at the NIH, there is an ongoing study about COVID vaccination and in the mitochondrial population. But until then, we generally recommend that we follow the CDC guidelines. The reason why we recommend protection against COVID and infectious infections is because we all know that mitochondrial patients can decompensate as a result of an infection. So we want to take all those possible measures As far as Omicron, we hope it's a milder version of the disease, but we've known about it for 2 or 3 weeks now. Still, the evidence is, and including there was a recent study published here within Mayo Clinic, the booster shot protects about 20 times against being infected or affected by the virus. So until more information comes in the near future, we will still recommend vaccination.
Yeah, I mean, I think this is something we all want, and for our own health is sort of straightforward answers, yes, no. Unfortunately, when it comes to something like a virus and over time that's changing, the recommendations will need to change along with it. And so even the booster, we don't know at this point. There may be additional vaccinations necessary. It could become annual for some period of time, as long as this coronavirus. So it's fluid, and I think we all have to remain somewhat flexible to what the science is leading us towards. So I'm going to turn to Dr. Parikh. Just in the course of the last half hour, 45 minutes, we hear about mitochondrial disease, some mitochondrial dysfunction. Oftentimes we talk about primary mitochondrial disease, secondary mitochondrial disease. I think some members of our audience are so confused, by this. Could you just kind of speak to those and where the appropriate use of these terms and how they fit within this community?
Sure. So when we are using the term primary mitochondrial disease, we are referring to a mitochondrial problem that has been genetically diagnosed. We know that there is a DNA change that is known to affect how the mitochondria work, or in keeping them healthy and functional, or helping you make new copies of your mitochondria. When we use the term secondary mitochondrial dysfunction, we are saying that there is something outside of the DNA, something outside of even the mitochondria itself that seem to be keeping the mitochondria from working well.
Yeah, I think, at the simplest form that's the case. And, it's no longer a scientific question of whether or not mitochondrial dysfunction is important to human health. It is across the board for every person, not just those that are affected by a primary mitochondrial disease. I know what, it's oftentimes exciting, an opportunity for us is to learn from the rare inherited disorders and perhaps how we fix problems within our patient community and how that might be useful in many other patient communities that have mitochondrial dysfunction as a component of it. So it really is a blending, right, of mitochondrial dysfunction into primary mitochondrial disease.
Absolutely. And some of this is also limitations in knowledge and technology and not having the right tools or treatments that we need. Everything from just getting older to having chronic disease, whether it be high blood pressure or diabetes, all impact how your mitochondria work. Receiving chemotherapy, having a severe viral infection, getting sick enough to be in the intensive care unit, like Dr. Tarampolsky said, vitamin D deficiency, all will impact how your mitochondria are working. Fortunately, many of those things are things that as our bodies heal and recover, we can also help recuperate and heal our mitochondria and get them working back to where they need to be. But for some things we just can't, and we do need to understand that better.
Yeah, absolutely. I just want to pause for a moment, remind our audience that you can enter questions into the Q&A box. The doctors and panelists that are not on screen now are keeping an eye on that and able to provide responses there. So please feel free to avail yourself of that opportunity. But for this group, I reflect back on the externally led patient-focused drug development meeting that we hosted with the FDA back in 2019. That one of the the major outcomes of that, of learnings from, we heard from the patients, it was that brain fog, right? This sort of cognitive issue of not quite being able to, have clear thinking, which is quite common across many forms of mitochondrial disease. And, Dr. Vernon, I was wondering if, perhaps you could kind of comment on that particular symptom and why do we see that so pervasively within mitochondrial disease?
Sorry, it took me a second to unmute there.
Okay.
I think of brain fog really as a mental fatigue. Just as the body becomes fatigued, the brain can become fatigued as well. And the brain requires rest the same way the body requires rest. And so often what I really discuss is all of the things that we think about maintaining our body health and our muscle health applies to the brain. It's important to have good sleep, good nutrition, stay hydrated, take breaks when you need to take breaks, a lot things along those lines. For example, some of my college students who have a lot of brain fog will actually work on scheduling their college schedules such that they're going to class every other day. So they have kind of a day to just rest their minds and recuperate and then go back to class the next day.
Yeah, makes sense. So it just has to be managed, right? Like any other aspect of the disease. Yeah. Dr. Gavrilova, perhaps you might have some thoughts on this as well.
So brain fog is, I also understand maybe is fatigue of the brain, but there are some mitochondrial conditions. MELAS could be one, and others. MERV patients also maybe have brain dysfunction in a way that their thinking, their memory, may be affected. So the medical term for that is different from brain fog, but I do not know the context of the question, so I may expand further. Your physician will be able to differentiate between brain fog, which is like more brain fatigue, versus a memory-related problem or cognitive dysfunction that could be a result of the disease that you're suffering. Mm-hmm. So in that case, if it is more severe, I'm not so certain that we have good treatment, and it is a result of the brain nerve cells not working well because their mitochondria don't work well. So we don't have a medication that can help with that memory or cognition, but we apply principles from other diseases. We know that memory and dementia, for example, with old age, can be improved by healthy lifestyle. So what that means, in addition to the sleep that we just discussed to restore the brain function, we also recommend mental exercise, physical exercise to improve the blood flow of the brain and clear the brain from toxins, good diet, and address all other health problems, control your blood sugar, control your triglycerides, which are commonly elevated. So these are kind of the bottom line is healthy lifestyle. Activity is helpful.
Yeah, makes sense for sure. Dr. Vernon, I'm actually going to come back to you. A question was asked about cancer and mitochondrial disease, and certainly mitochondrial disease patients are, may have cancer that can occur, as well as their mitochondrial disease. How does that impact their treatment in any way?
A lot of this, of course, is on a case-by-case basis. Mitochondrial disease individually is rare, but collectively isn't as rare as we once thought it was. And different forms of cancer individually can be rare, but some of them, of course, are much more common. We do tend to handle a lot of these cases case by case with generally really a team approach with a lot of us involved, trying to consider what medications and what therapies will have the biggest impact on things like catabolism and physiologic stress. We're much quicker to hospitalize our patients and support them with intravenous fluids and nutrition if necessary. But really, because chemotherapy can be such a huge metabolic stress on the body, it takes a very big team approach and a very sort of close observation of every patient. an ongoing basis. I'm interested to hear what my colleagues think of this because I've helped the oncologist manage a few cases, but as I said, everyone has been very individual.
Yeah, would any of the other doctors like to come in?
So I may just give an example, just as an idea. Very seldom chemotherapy can affect mitochondrial function, but there are chemotherapy drugs that can. We had a patient with mitochondrial myopathy whose weakness worsened during chemotherapy. So that tells us that it's important to watch if your function deteriorates with chemotherapy faster than what is normally anticipated. So in that case, how we approached that, we studied the effect of that chemotherapy drug on mitochondria, and we actually found out that that specific drug worsened mitochondrial function. So that led to a change of chemotherapy. So it's again, very individual. And the main thing to watch is your symptoms. If you have any symptoms and if they're worsened by chemotherapy, then please address that with your physicians.
Yeah, very good advice for sure. If there are no other comments on that topic, Dr. Gdansky, I'm going to turn it back to you. In the first panel, we talked about diagnosis of mitochondrial disease, and complex issue. A question was asked: if you already have a confirmed mitochondrial disease diagnosis through a muscle biopsy, does it still make sense to get genetic testing, something like a whole exome done? And maybe this is a good time to talk a little bit about how a muscle biopsy diagnosis is different from a next generation sequencing.
This is a fantastic question. I love this question so much. So muscle biopsy was once the gold standard of making a diagnosis of mitochondrial disease, because the muscles, one of the parts of our body where the mitochondria are the most active. They're doing the process of making energy. And so what you often get on a muscle biopsy is you find out how well your muscles are working to make energy. So you get how fast complex 1 is working, how fast complex 2 is working, how fast complex 3 is working, and how fast complex 4 is working. Someone asked a question in the Q&A earlier about complex 5. In America, we usually don't find out how fast complex 5 is working as part of that. That tells you how your mitochondria are dysfunctional. And this kind of gets back to the question that we talked about earlier with secondary mitochondrial dysfunction as well. It tells you how well the mitochondria are working at that particular moment in time. But it doesn't necessarily tell you why they're not working. I will say with a huge caveat, you can do other things with a muscle biopsy too. So you can look at how much mitochondrial DNA is in the muscle, something called mitochondrial DNA depletion, but you can also sequence the mitochondrial DNA, those very small percentage of genes that just are involved in the mitochondria that we inherit just from our mom. Some people with mitochondrial disease have mitochondrial disease due to a mutation in their mitochondrial DNA. If you find that in your muscle, so you know you have mitochondrial disease from a muscle biopsy that finds a genetic cause, like a 3243-AG variant or something like that, no, you don't need to do exome. That's your answer. But if what you've had from your muscle biopsy is functional testing that asks how good is your mitochondria working, in 2021, it's very helpful to complement that with genetic testing like a whole exome, because that tells you why your mitochondria aren't working. And as we talked about, if you have secondary mitochondrial dysfunction, how we want to treat you is different if you have primary mitochondrial dysfunction. And then hopefully by 2030, what I love to say to my patients is we know specifically why you have complex 1 or complex 3 disease. And here's a treatment that's very specific to this reason why you have complex 1 disease. It's a gene therapy or it's an enzyme replacement therapy. And so even though we can't do that right now in 2030, if I know your genetic cause, I can tell you, this is what I expect to happen next. This is the risk to your family of other people in the family having mitochondrial disease. And I might also say specific things like, I need you to see, not just the cardiologist and the ophthalmologist, which I ask all my mito patients to every year, but you specifically, you should also see the endocrinologist or the kidney doctor or the liver doctor. So there's gene-specific management.
Yeah,
That was a very long answer.
Well, I like this answer a lot, particularly with the importance of diagnosis. Oftentimes we hear, what difference does it make to get a diagnosis? There's no approved treatments anyhow, but you just made, a number of important points for why it is important to get to a diagnosis. It's about your clinical care. Your doctor can help you and make the best recommendations for how you live and manage your disease. But beyond that, it may impact family. It may impact what other specialists you need to see to give you the highest quality of life. So it sounds like in general, if someone had a muscle biopsy, and as you said, it was the gold standard, right, for so long, there may be a large portion of our community that through muscle biopsies were diagnosed. It makes sense to take that next step and get genetic testing to really get to the underlying pathology, right, from a genetics point of view. And any other thoughts from the panelists on this?
Yeah, one thing I'd actually like to add is a number of years ago when whole exome sequencing sort of came on as a more mainstream testing mechanism, some of the diagnoses we came up with, some of our patients who were diagnosed with primary mitochondrial disease ended up being quite surprising. And really changed the direction to a lot of things we were thinking about for their therapies, for their family, and for future members of their family as well. And, we still spend a lot of time managing the existing secondary mitochondrial dysfunction in those patients. It's still there. It's still very much present. But we realize what we're dealing with is actually something very different than what we thought we were originally dealing with. So I agree with everything that Dr. Ganetsky said about the importance of obtaining a molecular diagnosis.
And also, I may add, if we know what your genetic defect is, that actually helps researchers and pharmaceutical companies target those mistakes, so that this is how they do research on your DNA mistakes and try to correct them. So that will eventually and hopefully lead to gene therapy targeted treatments in the next decade, we hope.
Absolutely, 100%. Our goal is to get to those more personalized treatments in the future. Dr. Parikh, I'm going to throw a question to you here. Kind of similar to the cancer question, right? Again, many of our mitochondrial disease patients may be faced with the need for a surgery for something unrelated to mitochondrial disease. Any general guidance, particularly around anesthesia and mitochondrial disease when it comes to surgery?
Sure. In general, there is always a fear of certain stresses to the body, whether it be illness, infections, fasting, and anesthesia, potentially leading to worsening of symptoms. A lot of this was much more prevalent in the past. I think medical care has improved significantly. Preventative care for mitochondrial patients has improved significantly. And even the way anesthesiologists titrate their medications has improved. And all of this has led to less of a problem as a whole for our mitochondrial patient community and even our non-mitochondrial patient community. There is still a concern that mitochondrial disease patients may be more sensitive to certain types of anesthetics, and anesthetics do dampen mitochondrial function. And so they may need a lower dose patients for the type of anesthesia they're receiving. And so we do have guidelines available for your medical teams, and they're available on the Mitochondrial Medicine Society website. And they're called care guidelines, and they're not individualized to you, but in case you do not have access to a mitochondrial specialist or a mitochondrial center, these are things that you can take to your providers so that they can at least review this. And these care guidelines are broken down by specialists, so the person you're seeing does not have to spend hours reviewing a paper. They can just hone in on the table and section that they need to.
Yeah, fortunately, resources have been developed that really nicely catalog, the anesthetics that may be of of greatest concern, right, to mitochondrial disease patients. Bottom line is, your doctor and any other doctor, surgeon, otherwise, who's taking care of you needs to be aware that you have a mitochondrial disease so that they can consider the best paths forward if you need to have that surgery. So we have about 5 minutes left. And there was a question that came in that I thought was really fascinating. It's somewhat provocative, but I think it's an important discussion. And this is an opportunity to really hear the clinician perspective, on this webinar. And I think it's one that over time, we'll continue to explore. I'm going to actually read it because I thought it was really thoughtfully put together. Please share strategies or best practices that empower mitochondrial disease patients when encountering reluctant practitioners who are inexperienced with treating mitochondrial disorders. This may be medical alert bracelets, information cards, protocol letters, other forms of engagement, just as some suggestions, examples. The goal of these strategies would be to create opportunities to allow for two-way communication between the provider and the patient in a non-confrontational yet trauma-informed manner. So, again, we know many members of our community have faced this, right? Particularly if they're early in their diagnostic journey and they're still looking to kind of find their home. But what are your suggestions here? I'm going to go around and let each of you, comment to it. I'm going to start at the bottom of the screen. Dr. Parikh, you happen to be up down there. Maybe you could share your thoughts on this.
No, communication in medicine in general is a big concern. Electronic medical records and people using the same electronic medical record system has facilitated some ease of communication, but we still don't always use it enough. If you have a specialist that you trust, I would ask them to pick up the phone and call the provider who's not being attentive enough. I think that's been the most effective thing, hearing colleague to colleague what these concerns are, and that what concerns you're expressing are ones that we are all worried about for your health. I think that's not always the easiest thing to do, especially if you don't have a provider who's considered an advocate for you. But in the case that you do, that would be my first recommendation.
But you would agree, we have to acknowledge that there are members of the medical community that are still skeptical, it may be in a best case scenario, or just downright unaware of the prevalence of mitochondrial disease, and that it's really important then to use your entire network to support that practitioner.
Absolutely. And we do try and provide education as well. So in case you have somebody where it's just a knowledge-based issue, where it's like, okay, I don't know anything about this, but I do want to take care of you. I do want to be attentive and provide the kind of care that you need, then I would send them to Mito University, where the Mitochondrial Medicine Society, the United Mitochondrial Disease Foundation have partnered and created bite-sized content where they can spend 2-3 minutes to learn about mitochondrial disease, or do a deeper dive if they want. The Mitochondrial Medicine Society also has papers available for them should they need. I think the challenge, of course, which I suspect you're talking about, is what do you do to the caregiver who is not being attentive, or who is not, taking you at face value for the symptoms that you're reporting. And unfortunately, that happens all too often. And I don't think there is an easy answer for that outside of potentially involving the ombudsman at your institution, because the truth is, no matter what you're going through, just because we may not understand it or be able to diagnose it or help, you really should not be treated poorly or traumatized because of it. And if that's happening, I suspect the hospital system needs to hear, and the ombudsman needs to hear about it. That's the only way, one way that change can happen.
Yeah, it's important for the patients to know they have rights, and there are always representatives within any medical institution are there to hear your concerns, and that you can share them, and they can help you resolve those. I want to make sure we leave a little bit of time for the others. Dr. Vernon, any quick comments to this as we approach the top of the hour?
Yeah, I actually often think, general practitioners and people in other specialties, you can't know everything about medicine. I certainly don't know everything about medicine. And I always I'm talking with my patients, the litmus test really is that physician or practitioner or therapist willing to just pick up the phone and talk to me, or pick up the phone when I call, so that we can collaborate on care for this patient. And if that physician or practitioner or therapist is not willing to pick up the phone or not willing to answer my phone call, then maybe finding someone else who is the approach to take at that point, which I know is not always so easy.
Sure. Dr. Gavrilova.
So just think about a team around you, and that's what we often practice here at Mayo. We don't know everything about everything, but we work in a team with the patient. So if one physician may not hear what you're trying to say, try to say that to someone else. And it could be that someone else could be not your primary care, who may not hear your complaints, but just request and be open about that. I have those complaints. These are not addressed. Please send me to a specialist. And you can certainly do that. So they can advise you what is the best team that can look at your symptoms, address them, and then come to a consensus to a diagnosis.
Yeah, very, very solid advice. Complex problems often require a team and complementary expertise, right, to be able to solve them. So don't be afraid to ask for those complementary pieces where it may make sense. All right, Dr. Ganetzky, you're going to have the final word on this topic, and then we're going to need to wrap this up.
There's been so many good words said, but I think what I would add is, so many of our patients, we manage from far away, right? So there's fantastic teams at each of our institutions, but when you go home and none of your doctors know about mitochondrial disease, then what do you do? And what I often say to my patients in that situation is, you need to find one person who's your person, who can advocate for you, who can operate from an understanding of the medical trauma that you've been through, and who can, often they don't need to know mitochondrial disease to say, you have GI symptoms, you need to see a GI doc. Let me help you get into someone that I trust and like. And that person does not need to be a mitochondrial specialist, but tell me who that person is, and I'll get on the phone with that person, and they can get on the phone with your local GI or your local kidney doctor. And together we can really form a solid team.
Yeah, so it's really about not being afraid to express your concerns and ask for other voices to be involved in your care. That's what it comes down to. And it sounds like if that's done in a polite or respectful way, that most practitioners would be open to this to try to help create the team that it takes to take care of their patients. Well, again, thank you all. I do notice that my colleague, Kara, has posted in chat the link to Mito U that Dr. Parikh referred to. This is a great resource for learning. But patient community, you can also use this as a resource for your healthcare providers. You can point them to this. And as Dr. Parikh said, we've intentionally created the content bite-sized and short lessons on various topics that a community practitioner can come and learn about mitochondrial disease in a quick and informal way. So please take advantage of Mito U if you can. I'm going to thank everybody on this panel of a great discussion, and of course the doctors that were with us earlier in the evening. I think overall we covered a lot of ground. I know there are a lot of questions that have been coming through on Q&A. I've been keeping an eye on over there, and most of them we've been able to address, but we will do our best to get to as many as possible. Thank you all for sharing your time with us tonight from a panelist perspective. And to our audience, happy holidays, happy New Year, and we will see you in January for the next Ask the Mito Doc webinar. Take care, everybody.